Dear friends, good morning to all. I salute the Calicut team for the wonderful CASICON 24 for two reasons. Historically, this is the first conference which crossed 500 registrations. You could bring about 50% of the faculty to Calicut. Salutes. Second is this is the first conference who used a paperless platform. It's a way forward. I congratulate and I salute the team and work for this achievement. The question is, if you have a DVT patient, what to do? All of us surgeons, we are doing wonderful work. Dr. Jayamar has shown us a great work, a class, committed work for non-speciality. And often our patients may develop DVT and sometimes we are referred to some specialty and all those things. But we should be able to manage the DVT. DVT is very, very important. It's a very common thing in the surgical patients. And my talk is based on 2021 updates by American College of Chest Physicians. It was later remodeled in 2022. So as per these guidelines, I'm making some points. We are looking at 5 questions: how to diagnose DVT, who all needs treatment, and how do you treat, and how long will you treat, and do we do any monitoring during the phase? Diagnosis is most often confused. Many patients, such as cellulitis and cellulitis patients, are diagnosed DVT. DVT diagnosis is very, very easy. All surgeons should be able to handle the probe. With a probe, if you put on the vein and you apply some pressure, the normal vein will compress compared to the artery. So if you look at the leg or thigh, we can identify both femoral artery and femoral vein in the same compartment, and you apply pressure, the artery will remain like that, the vein will compress. If you demonstrate that you can almost exclude a DVT. Always look at the edema is present and exclude cellulitis, and ask for any patients with a DVT, ask for chest pain or dyspnea or swelling in the other areas. Doppler evaluation is very, very important. It's not only for the first time. That's why I said every surgeon should do it. You have to repeat it in 6 hours or 12 hours, looking at the progress of the lesion, progress of DVT, whether to decide any change in the treatment pattern also. So by Doppler, we should see where this exact site. Now the recent consensus says if it is below knee, it's a short segment, non-progressive, even no treatment is required. Particularly superficial thrombophlebitis, if it's below knee segment, short segment, again, we can manage conservatively without starting medicines. And all these patients need to be reassessed at time interval to see whether there's any progress of disease or the volume of thrombus is increasing or not. So the conservative line can be done for below knee segments, small clots, and non-progressive clots. So this is the picture. If you look at the artery and if you apply pressure, it is remain like that. But a vein, if you apply mild pressure, it will compress. That's a normal vein. If it is not compressing, you suspect a DVT in this patient without any augmentation if the patient does some Valsalva. So, and always look at which segment is involved. And these patients doesn't require treatment. The most important thing we have to do identify is whether the patient is a thrombotic or non-thrombotic, or unprovoked or provoked. That is the most important thing to decide what type of treatment it is. So if the patient develops DVT after trauma or bed rest or tight dressings, if they provoked one, and look at the previous history or family history of any DVT or any vascular disease in the patient. So to identify thrombotic, non-thrombotic, there are array of investigations, now 40 or 50 tests available, but these are the common tests: homocysteine proteins, antithrombin factor V, and APL, etc. So at least these tests should be done in all DVT patients, because this identifies the patient is thrombotic or not, and if the protein C protein is positive, warfarin is not effective, or APL is there, again, the drugs is not effective. So that's there. And next test should be a D-dimer. That tells us what's the risk of embolism. If the D-dimer value is very high, patient need to be admitted, patient need to be the bed rest, and we need emergency treatment. And as the progress of the treatment also, D-dimer is a good option. So all these patients, we should do a D-dimer test to identify the risk of embolism and follow up. Next thing is malignancy. 10% of DVT patients have some malignancies. So we have to look in 1 year follow-up, the recent studies. And also, as a surgeons, we should look at any possibility of malignancy in any part of the body, because unprovoked DVT can be due to an occult cancer. And particularly if you follow for 1 year, there will be 15% incidence. Particularly if patient belongs to any of these categories: old age, or patient is a chronic lung disease, patient having thrombocytosis or anemia, always you should look for malignancy in these patients. Acquired factors are basically immobility, the cancer, surgery, or infection. So for us, cancer and surgery are important. So once evaluation is over, we have to answer 4 questions, whether it's a DVT or not. If it's not DVT, think about something else. Whether the DVT is due to is the unprovoked lesion or a provoked one. If it's a provoked one, short treatment is required. And what is the site of the DVT and what's the volume of thrombus? And look at any underlying malignancy. After evaluation, we should be able to answer these 4 questions. Treatment is always a balance between two satans. One is bleeding, one is thrombosis. We should discuss the patient or all the options and all the complications, because if you overtreat it, they will go for bleeding. If you undertreat it, patient gain recurrent thrombus. So this is very important. This balance is very important in treatment of DVT. All patients need treatment. If it's a bony segment, if the thrombus is high volume. And that will reduce the amount of thrombus, that will reduce the amount of symptoms, reduce the amount of complications. How long? The treatment phase has 2 phases. One is a acute treatment phase. Second is a preventive phase. Treatment phase should be offered to almost all the patients, whether it's a provoked or unprovoked. That usually lasts for 3 to 6 months. Mostly 3 months enough. But prevention phase is optional, depending on the values, depending on the factors, the congenital factors, and depending on the patient's convenience. So always you have to discuss this with the patient before the patient putting on this patient. So prevention phase is usually after 3 to 6 months, and some patients may have to continue, some patients may not be keen on it because of various reasons. And in some patients, we can reduce the dose. If you start any drug on a full dose, you can make it half the dose during this prevention phase. So that should discuss the patient. And some patients may not be happy with the long-term anticoagulation treatment because of various factors. So that has to be discussed. The choice depends on the patient is having a risk factor, patient's job, patient's education, patient's affordability. There are many factors, but that should be informed to the patient in advance. The treatment are basically to address our local problems like a post-thrombotic syndrome, where the limb is affected very badly, or pulmonary embolism. So these patients need to treat it. How do you treat it? Always keep a patient at least for 2 to 3 days immobilization. Once you start the medicines, after 48 hours, patient can be mobilized. Anticoagulants are the most important weapon, and some patients, particularly if they involve the pelvic veins, a large volume, IVC involvement, you have to think about thrombolysis. So treatment should start immediately after diagnosis. Once you suspect a case of DVT, particularly a bony segment, even without confirming the diagnosis, you can start heparin or you can start some medications, because that may be life-saving. You have to start heparin, you have to hydrate the patient, then you think about heparin investigations. Weapons are many. You have medicines, you have injections, you have heparin. Which you select? Heparin is a classical drug, which was conventional, which is very well tested. It's a safe drug. Antidote is available, but only thing is very short acting. You need frequent injections, so may not be adequate for long-term patients. On the other side, low molecular heparins, you can give once-a-day injections, but it's little costlier, needs daily injections. And it is ideal for pregnancy-led DVT, and it is ideal for prophylaxis of malignancy when it is involved in the GI tract. And this patient can also. Warfarin is again a time-tested one, good for preventive treatment. It's like oral medications, but the only thing is you have to monitor a PTINR regularly to keep the PTINR in a small window. That's the issue. So newer agents are available, docs. They are fixed dose drugs. You don't need any monitoring. You can only very few interactions are there, but question is this is costlier. No effective antidotes are available, and few antidotes available, but it's not easily available. That's the issue with them. You have a dabigatran, you have a rivaroxaban. Everybody has heard about these medicines. They are fixed dose. They can be used in various conditions. Among them, rivaroxaban may be the most trusted one, which can be used safely in most of your patients. If it's a cancer, because we get a lot of cancer patients. If it's a cancer, it's involving non-GIT part, the best is go for the rivaroxaban or apixaban. If GIT is involved, you can go for low molecular heparin or apixaban. That is the consensus now. So how do we monitor these patients? As I said earlier, if it's heparin, low molecular heparin, or a dox, there is not much monitoring is required. But if the patient is on warfarin, you have to maintain a PTINR in a desired level. That's about 1.5 to 2.5 range. Once if you're planning as a surgeon, if you plan for a surgeon in a DVT patients, if you're planning for a minor surgery, stop the medicines 2 days prior to its procedure and put him on heparin or normal heparin because heparin is an antidote. And we can restart the medicines 24 hours after the procedure. If it's a major procedure, stop 3 days before surgery and restart it after 2 days of the procedure. That's a safe way to manage these patients when it's patients on this anticoagulants. So this is bridging out therapy. I'm not going to provoke this. The principle is if it's a provoked lesion or all DVTs, the treatment phase is 3 to 6 months. If it's an unprovoked one, it has a positive factor. Think about a long treatment. Sometimes some people needs lifelong treatment, particularly if patient has more than 2 episodes, patient has any evidence of pulmonary embolism, think about a lifelong treatment. And if it is first episode, you can stop it after this in the patient. You can stop the medicine after 3 to 6 months, but patient should be advocated that there's a possibility of restarting these medicines if patient develops one more episode of DVT. So that's the consensus. Some people ask, can I travel the treatment? Yes, they can travel with some prophylaxis and with some compression stockings and all those things. So the 2021 recommendations are very clear. Every patient of VT should get a treatment phase of 3 months, depends on choice. It's your convenient, the patient's convenient. If it's acute DVT, better is go for doc is the apixaban and dabixaban choice. If it's extended anticoagulation, most data says most of this patient requires only up to 4 years. Even after 4 years, you can reconsider it. There is not much advantage if you continue medicines more than 4 years. If it's isolated distal leg DVT, better the follow-up the patient, do a follow-up scan, see the volume of the thrombus is not increasing, see the clot is not progressing. You can treat the patient because the risk of pulmonary embolism is very, very low in this category of patients. So they don't need an anticoagulant most times. If it's an APL is important. In our when there's APL is present, warfarin is the drug of choice, not rivaroxaban. So that's the principle of management. So the message is very clear. DVT, we will have DVT patients in our among our patients. We should be able to treat it. We should properly evaluate it. We should understand it. And most of these patients can be saved from pulmonary embolism, from post-thrombotic syndrome, and other complications. Thank you very much.
Very informative talk. Covered almost all the important points about DVT and open for discussion. Dr. Prathapan.
Excellent talk. I have a doubt because some of these patients will be put on DVT treatment by some surgeons, and these patients may come for other procedures to a different persons. So when can we stop these drugs? Sometimes the patient might be taking rivaroxaban or some other drug for 1 year, 1.5 years. But is it required to start heparin and stopping the DVT drug, or can we stop it at that itself if the imaging shows no evidence of any DVT related issues?
Yes, that's a good question. The thing is, patient the acute phase or the treatment phase, we have to conduct all the patients should get heparin. You stop, maybe Dr. Pradhapan's case are major procedures. You stop it 3 days before the procedure, start put them on heparin if they are on treatment phase. If they're a preventive phase after 1 or 2 years, even you can manage without heparin also. But in the first 3 months, we should start heparin. We should be on heparin when you're taking the patient for surgery.
Last comment, sir.
Morning, sir. Excellent talk, sir. Just a query. We had a somewhat similar question related to what Professor Pradhapan had asked. We had a patient recently referred to us. This patient had a fracture in both the legs, and the leg on which they planned for a surgery, fortunately, there was no thrombosis. But the opposite side, the patient had thrombosis. So they wanted to know whether they can do surgery. Suppose that thrombosis was on the same side. What could be done in those scenarios?
Whatever it is, we can do the procedure under heparin. No issues.
Okay.
That's the way it has to be done because we have an antidote. It acts only for 1 hour. We can do the procedure under heparin, and that patient should get heparin.
So is there any time where we have to do the procedure
Nothing like that.
after giving heparin?
Yes, heparin act in 5 minutes. We can start after 5 minutes after the.
Okay,
No issues.
thank you.
Thank you, sir.
Thank you, sir. Thank you, sir.